Hi, I'm Dr. Tim Kosinski from Bingham Farms, Michigan, and today I want to demonstrate one of our atraumatic or minimally traumatic extraction techniques using the salvin-dental autotome. Removing a tooth such as this unrestorable maxillary central incisor can be challenging in certain situations. You can see here with our periapical radiograph that we have a tooth that was deemed non-restorable and symptomatic. Our CBCT analysis illustrates a tooth that has had several treatments over the years, but also a facial plate of bone that can be traumatized during an extraction. Maintaining that facial plate of bone is very important to me in that in this situation I want to immediately place a dental implant. So our CBCT analysis is very important. We remove the crown, which was falling out, and you can see our patient is unhappy with the aesthetics, and we determined that a dental implant is a viable alternative to conventional dental treatment. So as a transitional, we took his existing crown and we simply made an Essex retainer, bonding the existing crown into a plastic suck-down matrix, and this is what the patient would wear immediately following surgery. So we see a tooth that, again, is deemed non-restorable, and there are several techniques to remove this tooth. Many of us would use a periotome and then an elevator or luxator to try to remove the tooth, but it can be challenging in that we have existing crowns on either side of this area. So another technique that I find very useful is the salvin-dental autotome. An autotome is simply an instrument that is hooked onto my implant motor, set at 1:1 at 10,000 RPMs, and it is simply a periotome that will extend into the handpiece, and you can see how when I press the foot control, it actually kind of taps, and what it's doing is it's engaging between the existing tooth and the viable bone around the tooth that is going to be extracted. So it's a very non-invasive procedure. The patients really don't experience a lot of discomfort in this. Obviously, we did anesthetize the patient with Septocaine in this situation. But I'm simply going around the tooth with this autotome, and there's a slight tapping motion. You can see the instrument going in and out, and you're getting much more torque than you would with a conventional periotome using just hand pressure. So I'm simply going around the tooth using the autotome, breaking down the periodontal ligament between the viable bone and the tooth root itself. And I'm going fairly far down the root structure, probably 4, 5, 6 millimeters, and you can see the bleeding created is the breakdown of the periodontal ligament. Now what's holding this tooth in position, this root in position, is the periodontal ligament. So once the periodontal ligament is destroyed, then the tooth should be easily removed. And here I'm taking a tooth delivery instrument or a forceps. I'm putting pressure and simply rotating mesial and distal, holding, and again the periodontal ligament is basically destroyed, and you can see that the tooth is removed relatively atraumatically. This tooth was actually fractured and we were able to remove the pieces in total. The socket site is evaluated and curetted. Now we curette. The digital radiograph illustrates that tooth is removed in total. We're going to create any granulation and purple blood from the site. Now I'm simply going to use my osteotomy burrs to actually make my an osteotomy for in this situation, the Glidewell Hahn dental implant system. I'm taking a 2.4 diameter pilot burr, and I'm actually engaging the palatal wall of the socket. I never want to put the implant directly into the socket site because, again, the facial plate of bone was relatively thin. We want to make our osteotomy about 3 millimeters palatal to the facial aspect of the adjacent teeth. This allows room for the eventual abutment and final, in this situation, Bruxer aesthetic crown. So I'm engaging the palatal bone. I'm going to take a radiograph to ensure my angulation mesial distal. Buccal palatally, I want to engage about 3 millimeters palatal to the facial aspect of the adjacent teeth. So it looks like I'm in pretty good position here, and I'm simply going to widen the osteotomy with my subsequent burrs. And this happens to be a 3.0 diameter burr. Now, when we're doing our immediate implant placements, I do want to place the implant about 1 millimeter subcrestal. This is a physiologic position because we do expect a little bit of bone loss. I'm using my existing root structure to determine the length of implant that I'm going to place. Again, I'm widening the osteotomy to the shape of the implant, and you can see I'm about 1 millimeter or so subcrestal, and then finally widening to my final osteotomy burr for the 4.3 diameter dental implant. And again, this is a very important photograph. You can see my position is very precise. I'm not in the socket site whatsoever. Rather, I'm about 3 millimeters palatal to the facial aspect of the adjacent teeth. Again, I constantly take radiographs to ensure my correct position. Now this is very interesting because the socket site is shaped like an egg or wider than the round implant itself. I want to graft the site, and what I do is I'm going to take my implant and thread directly into the implant. The material will then be extruded to fill any of the gaps. My Han dental implant is then strategically placed in the socket site to the crest, and here I'm torquing it into position to 35 Newton centimeters, the immediate post-op placement. The implant is actually then torqued to 45 Newton centimeters, and you can see that I am now subcrestal, about a millimeter, millimeter and a half or so. I put a healing abutment into the implant and torque the healing abutment to 25 Newton centimeters. This will allow the tissue to form a nice cuff around the implant and eliminate a secondary surgical procedure or the need for anesthesia in the future. And you can see my postoperative CBCT analysis illustrates nice positioning of the implant, about 1 millimeter subcrestal. We had great stability, initial stability at 45 Newton centimeters. Because I was able to torque the implant and get that initial stability, I put a healing abutment into position, which will again eliminate the need for secondary anesthesia and incision of the tissue. The Essex retainer with the patient's old crown is then seated, and we were able to provide the patient an immediate implant placement, a two-stage procedure where I place the implant and a healing abutment. We'll allow this implant to heal for about 4 months prior to making our final impression. I was asked to demonstrate a new technique that's very, very helpful in our practice, and that is the use of the Penguin RFA torque determining device to help determine implant stability with objective measurements. So we have a patient that we have a healing implant, and I'm simply going to remove this healing abutment with my little tool. And the implant has integrated for about 4 months. And then I'm simply going to take the Penguin multi-peg, and I'm going to thread it into my implant. Just hand tighten it. Pretty routine. Hand tighten. And the Penguin unit is self-contained, very easy to transport. And so to take this stability measurement, I'm going to connect this multi-peg to the implant, and then I'm going to turn the Penguin on, and I'm simply going to direct it towards the magnet at the top of the peg. I'm not touching it. The peg is stimulated by magnetic pulses and vibrates due to the stiffness in the contact area between the bone and the implant interface. And you can see our value is 79. The stability of the implant is indicated on an ISQ scale of 1 to 99. And by taking a baseline value at implant placement, it really does give us a great relationship as far as osseointegration. And generally, values above 70 indicate a very stable implant with low micromobility that can withstand normal function forces in the mouth. And this confirms that
loading of this implant is appropriate. So I feel really good about it. I'm going to put my abutment and my final crown, and we'll show you that, and we'll be all done.